FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.
Esse é o FRêMITO Podcast Vascular, direto do Congresso Science 2023, e a gente está tendo a honra de receber aqui um convidado internacional, o Dr. Shan Lo, de Nova York. Vai trocar uma ideia com a gente, passar a experiência dele sobre colo hostil. Shan, you are very welcome. Thank you for your time to join us.
Thank you very much for having me. Pleasure to be here.
Very nice. So one of your subjects here in the meeting is about hostil neck. And what does qualify a hostil neck?
Yeah, so hostil necks, I think, is one of those areas that we've struggled with when we do aortic repairs, especially endovascular aortic repair. And basically what it refers to is anything where it's going to make the seal of your stent graft difficult in the neck. So traditionally, I think most people think of it as like a short neck. So that's the most common one. But it also applies to necks that are starting to become big, so become an aneurysm. It also applies to factors that are going to make it hard to seal, such as calcium, thrombus, big angles within the neck. So all of those elements means that either your graft may not seal, or it may not last. And those are the things that we need, the challenges that we face now, because as we do more stent grafts, the problem we're facing is a lot of them are coming back, failed, and they were really hard to fix at that point. So I think it's important to recognize when you have these and then make the appropriate selection.
Talking just about the length, what is a short neck for you?
Yeah, so I think everybody has a little bit of a different take depending on which graft they use. But if you look at the data, all the data would suggest that really you need about 15 millimeters. Now, there are grafts that will allow you to go shorter, but all the studies that have been done really show that under 15, you start to lose some of the benefits of that neck. So I think really 15 millimeters.
And nowadays, which options do we have to treat those hostile necks?
Yeah, so we have a number of options. And again, I think everybody has their own preference depending on what they believe. I think that the majority probably believes in going higher. So that means that you need to go to the aorta that's healthy. And so that means using one of the advanced grafts. So whether you do a fenestrated graft or a branch graft or some combination to go to the segment of the aorta that's not compromised. But there are grafts that can go shorter, 10 millimeters, 7 millimeters. And then there are a couple of devices that maybe allow you to extend the life of a graft. For example, if you have an older patient and you don't necessarily need the graft to last, a very long time, then maybe simpler is better.
What's your favorite option in your daily practice?
For the majority of the patients that are not frail and not old, I prefer to go higher. So that would be using a fenestrated graft or a branch graft or a custom-made device, I think is the appropriate option that I believe in. But I do get a lot of frail patients and older patients. And so for those situations, I will use grafts that are designed to seal in shorter necks or anchors or something just to buy them more time, because I understand what's the goal of the treatment.
And when do you prefer to use other options as endo anchors?
Mostly older and frail patients. I think if you want durability, I do think you need to go to the part of the aorta that's higher, or just healthier.
But go higher is only to use T-branch, or there's other option for that?
So there,
custom made,
just for the renals, for example.
Fenestrated. Yeah, I think that. So number one in the U.S., so fenestrated is available. The other devices are still in trial, but I have access to them through one of my partners. But I think that, you have to balance against covering more because there's more risk, right? Yes. So I think that depending on how much, if you have a short neck that's say maybe 4 millimeters or thereabouts, then I think and the rest of the aorta looks okay, then a standard fenestrated is probably a reasonable choice.
When you have a patient who is not frail, a younger patient, what is your specific threshold when you decide to treat, go higher or just treat infra-renal?
Yeah, so I think there's age and then there's what the patient's really looks like. and they're not the same.
Yeah, exactly.
Especially in the U.S. So I have a lot of 50-year-old patients that look like they're 90, and I have some 90-year-olds that really look like they're 60. So I think it's important to say that if you have a really young patient, so under 60 years old or even the low 60s, you do need to offer them an open surgery, and I do offer them open surgery. Because some people just don't want to be bothered with the possibility that the graft may fail with time. And I'm not necessarily sure that using fenestrations and branches in somebody in their low 60s is going to last them 20 or 30 years. We know that the branches can fail over time. So I think open surgery is an important discussion. But generally speaking, if they're in their late 60s, 70s to late 70s, I think it's a good choice to use one of the advanced grafts that we have available. I do it up until about probably the early 80s, but then after that point, if they're healthy, but after that point, I really look for other choices.
Okay. Very nice. And not about the length, but about the angle.
Yeah.
How many options do you have to solve angles more than 60?
Yeah. So we have one right now, which is the Gore conformable excluder. And I do use it. I really do like it. I think in the 60 to 90 degree range, it works very well. It also works quite well in the 45 to 60 degree range as well. I think the challenge is if you get an angle and you get a short neck together.
Okay.
Those are very challenging. And so those are very hostile. And then so those cases, I think it depends on your experience. If you understand how to build a fenestrated graft in a angled neck, then yes, you can build it. And I have done that. If it's really angled and the vessels are taking off in a very strange position, then really I think a branched graft is typically what I would typically choose, mostly because it gives me safer, so I don't misalign the holes, especially if I built it wrong.
Okay.
So.
For fenestrated or branch grafts, what is your bridging stent preference?
So for me, it's VBX, which is the Gore balloon expandable stent. I have found that number one, so I don't think we have as many options, and we have a couple of new ones coming that I'm going to probably try. But for example, the iCast stent that we have, which I think is called differently outside the US, is very stiff. It's not my favorite. It doesn't take the turns well.
It's crazy for us because I had the opportunity to stay in US last year for some months, and I think I saw 4 or 5 endografts there. And here in Brazil, we have more than 14.
Yeah.
So it's crazy for us. And bridging stents, we have so many China stents device.
Yeah. I think that can be challenging, though. I mean, too many options makes it very difficult. Because how many people?
Is like
right. How many people really know how to use more than say?
Yeah.
Most people in the U.S., I will tell you honestly, outside of the academic, can only use maybe 1-2 grafts at most. Mm-hmm. In academia, maybe we use 4. I'm comfortable with about 4 different grafts, but that's probably the limit. I mean, at some point, there's just too many.
For most patients, it's enough.
Yeah,
if you know how to use like 4 or 5.
I would say if you knew 3 to 4 grafts, you can probably treat almost the majority, almost all of the patients. Just very few that are very rare.
The only thing that I think is better is because the market share the price, so the price comes cheaper, is more competitive.
That's true.
And only 4 companies in US. I think it's because FDA it's very huge.
Strict.
Yeah, exactly. Shan, in your opinion, what is the next frontier to solve AAAs?
Well, so there's some interesting developments that one of which I just was presented at SVS, which is that the new medication that they're applying via balloon to try to stop the growth of the aneurysm. I think that what we're doing is we're treating the result of a process that we need to figure out how to stop it in the first place. So ultimately, I think. And I'm talking decades down the road, I think we need to look into the genetics and figure out what we can do to kind of slow down the situation. But I think that in the U.S., what I would say is the next immediate step is to get people to recognize when it's proper to use the graft and when you should not use a standard infrarenal graft. And maybe you should send it to a facility that can do all of it. because the problem that we're having, the big problem we're having, is how many people are coming back with failed grafts. And if you look at the original implant, the CT, usually they're off the label.
Yes.
And that's the problem. I think the grafts perform very well if they stay within the label that they're described, which is usually somewhere between 10 and 15 millimeters of neck. But once you cross that, you know, and so that's one of the bigger problems in the U.S. I think that a lot of people are doing them, and they're not really paying attention to whether they're doing the right thing for the patient.
Let me change the subject and ask you about the residence trainers in U.S. Because here in Brazil, we are deal with some difficulty to train the residents in open surgery because most of the case goes to endo. How do you deal with that in your university?
Yeah, we have the same problem. So the governing body for our trainees just dropped the requirements for open aortic work from 30 to 15. And that was because when so I used to be a program director. When I sat on the committees for that, most people were graduating with about 10 to 15 cases. That's it. There were some programs that graduated with 0.
Whoa.
Open, okay.
So how do you expect them to take call? And then they're going to call a senior partner because they've never really done it and they're not comfortable.
It's not going to be an option, right?
Yeah, I think that some of the creative solutions that have come up were to basically look at other places. So, for example, Canada, because of the way the medicine system is structured, they do endo, but then at some point they do more open because of they have constraints on how much they will spend on the materials and the endografts. So they still do a fair number of endos. So I know some places are sending up to Canada to get the exposure. At University of Pennsylvania, we still have enough. It's not like it was.
Sure.
My junior partners, they're very good, but they still are a little bit, hesitant in certain situations that they may not have seen as many. So, but I think the standard open infrarenal, I think you're going to have to collect all those cases, and then people are going to have to send them there for training. There's no other way. And then simulators.
Okay. And as a take-home message, how could you finish your presentation, like for a person that couldn't watch what you were speaking here in the Congress?
Regarding hostile necks overall, I think it's the take-home message is understand what constitutes a hostile neck, identify it, don't ignore it, and then if it really is that challenging, if you have the skills and you have all the options, great. But if not, really seek another opinion.
Yes.
And then maybe that other opinion will give you some, other options that are available that maybe you didn't know about and may be better for the patient. Because ultimately, I think we need to make sure these repairs last longer than they are now.
Thank you, Shan, for your time and to teach us something.
Thank you very much for having me.
You did very well today in the run.
Oh, a little slower than last year, unfortunately.
Não deixe de continuar acompanhando os episódios do FRêMITO Podcast direto do Congresso Science 2023.
FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.